Welcome to the deep dive. Today we're getting into something pretty serious affecting a lot of young women worldwide.
We're talking about recurrent urinary tract infections, UTIs, but with a really important twist.
Yeah, specifically looking at this dangerous superbug, ESBL Klebsiella pneumonia.
Exactly.
Right.
ESBL stands for extended spectrum Beta-Lactamase. Basically, these are enzymes bacteria make that just chew up common antibiotics, making them useless. It's a multi-drug resistant organism, and it's really changing how we have to think about recurrent UTIs.
And these recurrent infections are already so common, right? Something like 14.5% of women get them again after the first one.
That's right. But the kind of surprising part we want to unpack is how often this superbug is the culprit now and, why that's happening.
Okay, let's dive in. What makes someone more likely to get these recurrent UTIs in the first place?
Well, it's fascinating, really. The factors range quite a bit, from lifestyle things to, maybe even your genes.
So what are the big ones? I read that how often you have sex is a major factor.
It really is. Intercourse more than 9 times a month that boosts your risk tenfold. It seems to be mostly about the mechanical transfer of bacteria.
10 times. Wow. And there was something about age, too.
Yes, if your very first UTI happened when you were under 15, your risk for recurrence is almost 4 times higher later on.
Huh. And what about that genetic link you mentioned?
It's suggestive. If your mother had a history of UTIs, your own risk is about 2.3 times higher.
That's really interesting. So potentially an inherited susceptibility.
Could be. Other things too, using spermicides increases risk about 1.8 times. And having a new sexual partner in the last year, that raises the risk by 90%.
So it's this mix of behavior, maybe biology. It's complex.
Definitely. It highlights how tricky prevention can sometimes be.
Okay, so against that backdrop of common risk factors, now layer in this ESBL superbug. You said it's becoming more common.
Alarmingly so. In some places, it accounts for maybe 30 to 40% of all bacteria isolated from urine samples.
And what makes ESBL Klebsiella specifically such a threat?
Its resistance profile. These bugs shrug off many of our standard UTI antibiotics. We're talking cephalosporins, penicillins, often fluoroquinolones too, like Cipro.
Right, the common go-tos.
Exactly. And here's the critical link. Having recurrent UTIs is actually the strongest risk factor for getting an ESBL infection.
Oh, really?
Yeah, studies show about 46.5% of women with recurrent UTIs have ESBL organisms involved. Compare that to just 27.3% for first-time UTIs.
So if you keep getting infections, the odds of it being this resistant type really shoot up.
Precisely.
And the consequences sound dire. I saw a statistic about sepsis mortality.
It's stark. If an ESBL UTI progresses to sepsis, the bloodstream infection, the mortality rate is around 52%.
52% compared to
about 29% for sepsis caused by non-ESBL UTIs. It's nearly double the risk of dying.
That is terrifying. Why is it so much deadlier? Is it just the lack of effective antibiotics early on?
That's a huge part of it. The resistance means treatment is often delayed or ineffective, allowing the infection to overwhelm the body. But there's also this sort of paradox. Go on. Especially for young women. Using antibiotics previously, even just one course within the last, say, 4 weeks to a year, dramatically increases your risk of the next infection being ESBL.
So the treatment itself can backfire.
In a way, yes. It wipes out susceptible bacteria, leaving the resistant ones like ESBL Klebsiella behind to flourish. We're even seeing more community-acquired ESBL UTIs now in young, healthy women who haven't necessarily been hospitalized.
Okay, this sounds like a huge treatment challenge then. If the common drugs don't work, and using them might even worsen the risk next time, what's left?
It forces a total rethink. For severe hospitalized infections, we still have carbapenems. They're powerful, given intravenously.
But not for a typical outpatient UTI.
Right. For less severe ESBL UTIs managed outside the hospital, you're basically down to just 2 reliable oral options.
Only 2. What are they?
Fosfomycin, it's often a single 3-gram dose, and nitrofurantoin, which is usually taken for several days.
And how effective are they? Is the resistance to them too?
There is, but it's generally much lower than for other drugs. Fosfomycin resistance is somewhere between 5 and 40%. Nitrofurantoin maybe 2 to 21%. Still, compare that to fluoroquinolones, where resistance can be super high, like 49 to 72%.
Wow. So choosing the right antibiotic first time is critical.
Absolutely crucial.
Yeah.
Which is why identification matters so much. If you have risk factors for ESBL like recurrent UTIs or recent antibiotic use, you really need a urine culture before starting treatment.
Not just empiric therapy based on symptoms.
Exactly. because delaying the right antibiotic significantly increases the risk of serious complications, even death.
Okay, so getting the treatment right is key, but difficult. This puts a lot more emphasis on prevention, doesn't it?
It really goes. We need to lean harder on non-antibiotic strategies.
Like what? What can you actually do?
Some simple behavioral things can help. Postcoital voiding peeing after sex, staying well hydrated, aiming for maybe 2 to 3 liters of fluid a day,
Okay.
and avoiding spermicidal contraceptives if you're prone to UTIs.
What about non-antibiotic medications or supplements?
That's a growing area. Methanamine hippurate is one medication that works by releasing formaldehyde in the urine. Studies show it can be as good as daily low-dose antibiotics for preventing recurrences.
Interesting. And things like cranberry or D-minnows?
The evidence there is, well, it's promising but mixed. D-mannose seems to work by preventing bacteria from sticking to the bladder wall. Cranberry products might do something similar. Probiotics are also being studied. They show potential, but we need more definitive data.
So not a magic bullet, but maybe part of the picture.
Could be, for some people, worth discussing with your doctor.
Okay, so to wrap this up for you listening, recurrent UTIs in young women, they're common, yes, but getting much more complicated because of this rise in ESBL resistance. It's really changing the game.
Absolutely. So if you're experiencing recurrent infections, the key takeaway is insist on getting urine cultures done. Don't just accept another standard antibiotic without checking.
Right, and talk to your provider about non-antibiotic ways to prevent them. Make sure your doctor's actually up to date on these local resistance patterns too.
Exactly. And be aware of your own risk factors, like recent antibiotic use.
So the future here isn't just about finding brand new miracle drugs, is it?
Not entirely. It's just as much about being smarter with the antibiotics we do have, using them targetedly, and really embracing these preventative strategies to try and stay one step ahead of these evolving superbugs.